Hi, welcome to Case of the Day. I've made a little change here that I will also um, add cases whose biopsy reports I have received the same day, because otherwise, what's happening is that many good cases become difficult to discuss. Because if the result is not available, then it just becomes pointless. And though earlier I've put up some posts and then added the diagnosis back in the description, it doesn't seem to have helped. So this is a little maybe it's a little cheating, but that's okay. So that's we've reached 50 cases, right? And thank you so much for encouraging. There are a lot of you who are seeing this, so that's encouraging, right? So today's case is back to first principles: the power of absence of enhancement. 45-year-old psoriasis unrelated, exposure to index case of TB, so came for a CT scan. There was a lesion here. I don't think it was picked up in the report, but I'm not sure. I didn't have the report, but nevertheless, patient comes for a CT. That's the lesion here. It's straddling the major fissure, indenting the superior segmental bronchus and the superior segmental bronchus of the left lower lobe and the superior lingular bronchus. And so the question will be, what do you think it is? I mean, it could be a lymph node. We're looking for stigmata of TB. Is it a medial pleural or a fissural nodule? Is it a lung nodule crossing the fissure? In which case, is it a neuroendocrine tumor? Classic case, classic age and presentation. So that's the contrast study that we did. And typically, if you were to look at the contrast study, you'd eyeball it and say that there's a subtle heterogeneously enhancing lesion in the left hilum, and then you wouldn't know what to do with it. But if you go back to first principles and you look at the plain scan and then the contrast studies and take the effort to measure the Hounsfield values, you'll realize there's no enhancement at all. And when there is no enhancement, it means it's either fluid, that is a cyst, or dead fibrous tissue. It's not a necrotic node, because a necrotic node would still have a thin enhancing rim. Now, if this is a cyst, then this is likely a bronchogenic cyst. So that's our diagnosis. So these are the first principles. Measure for any chest scan. There should be at least one end inspiratory scan. Look at the plain scans to see whether a lesion is enhancing or calcified. Ask for old scans, x-rays. They are gold mines. And remember, I started this whole case of the day with one of those, and I'll put up the link at the end. And trace the bronchus and history. I've done a whole lecture on this, but today just let's look at the whole concept of looking for enhancement, and looking at the plain scan. So here's a 43-year-old, had a COVID CT, had the subcarinal lesion, had two different densities, was sent for a CT guided biopsy because it was mentioned as a subcarinal lymph node. But if you look at the plain and the contrast scan, there is no enhancement. It goes from 56 to 58, which is not enhancing. And both components didn't enhance. That's 1.3 and 1.5. So if there's no enhancement, it implies that it's a cyst. Patient didn't agree, so we did a PET CT. There was no uptake. Finally agreed that a biopsy was not required and you can just leave it alone, and that's a bronchogenic cyst. So if you follow basic principles, you can obviate further investigations typically when a lesion absolutely does not enhance. And so if any lesions greater than 10 millimeters, you can use this rule. Like in this lung nodule, also we knew that it hadn't changed for 3 years. But if you look at this here, on the contrast studies, plain venous delayed, there is absolutely no change in the HU. It's 17, 16, and 12. And on the dual energy, we did the iodine, and there's no iodine uptake as well. Here's another patient sent for a CT guided biopsy for this lung nodule post cabbage. And it looks like it's enhancing. That was the way the CT had come. That's the retrocardiac density. But the plain scan shows that it's diffusely calcified. So if you look at only the contrast, it looks enhancing, but it's not. It's just a diffusely calcified lesion. You can leave it alone. We try to trace the radiograph and that nodule is there. It's just not well projected here. And so then it obviates the need to do anything. So the moral here is that look at the plain scans. Forget the moral. I hate that word. So the learning here is that there is definite enhancement. If the lesion is not calcified, look at the plain scans. So if the lesion is calcified, doesn't enhance, you can leave it alone. That's the important thing. That's the Leadership Summit, my WhatsApp channel. And thank you, for viewing this. Take care.